us today. Today's conversation is about something many of us are experiencing firsthand. As you all know, healthcare has become incredibly good in identifying who needs help, but we're still struggling to consistently engage them at the right time, at the right moment, guide them through increasingly complex processes like Medicaid renewals, and ultimately confirm that people actually receive the support we need. And our partners, Public Health Solutions, has become one of the leading organizations in New York, helping residents achieve just that and navigate these moments. They've supported hundreds of thousands of New Yorkers through Medicaid enrollment, renewal, while building partnerships across healthcare, social services, and community organizations. So I'd like to take a quick moment and allow Zach and Luz to introduce themselves.
Thank you, Alex, and good afternoon, everyone. It's a delightful to be here, although it is not delightful outside here in New York. We have wildfire smoke and extreme heat, and you know, there are today's conversation is going to be very public health oriented. So please do keep hydrated and keep cool if you're dialing in from New York. I'm the Chief Strategy Officer at Public Health Solutions. I'm also Executive Vice President of our WholeYouNYC Social Care Network. And Public Health Solutions is our mission is health equity. We are focused on closing the gaps that we see across health outcomes in the city. And I'm really excited for today's conversation because I hope we can bring a variety of experiences and expertise to the table in addressing how we create access under the evolving policy landscape of Medicaid. Luz?
Yes, thank you for inviting me. I'm working for Public Health Solution for more than 13 years. I'm very glad to be here. I hope we can share information important that we can help our community, and I appreciate that. I'm New York State Navigator certified, and I'm glad to be here. Thank you.
Thank you so much, Luz and Zach. And I'd like to start by zooming out. You know, everyone talks about member engagement, but very few organizations have successfully operated engagement programs at scale like Public Health Solution has. So with that said, what operational lessons did you learn from serving more than 600,000 New Yorkers that others could apply?
Thank you so much for that question, Alex. You know, engagement at scale, first of all, engagement as a term is not a public health term, it's a healthcare term. And, sometimes it's a challenge. It's a term I grapple with in a challenging way because its meaning is obscure. And what is considered engagement can often not be very meaningful. And to be impactful at scale is to really acknowledge that there isn't one effective method of engagement. If you want to uh, achieve universal or large scale engagement, you have to use a health equity approach in order to be effective at scale. What do I mean by that? Because health equity and equity's name has been tarnished, but at Public Health Solutions, when we think about health disparities and we think about health uh, inequities, what we are acknowledging is that it's not a one-size-fits-all approach, that to achieve good outcomes across the board, you have to recognize that people come from different backgrounds and different life experiences. And so you have to have a lot of different tools in your toolkit today. When asked about doing this presentation, the first thing that I said is that I have to do it with a navigator. And that's what brings Luz on with us today. And why I made that request is because Luz has the most experience in terms of understanding the different ways to be effective with engagement. And yes, we're going to talk about technology, and we're going to talk about infrastructure. In today's conversation, I will represent what's possible with infrastructure, and Luz will represent what's possible through human face-to-face engagement, so that hopefully our audience today will come away with how those can be brought together to address some of the policy changes we're facing on the landscape.
Yes, it's okay.
Yes, please go ahead.
Okay, in my case, as Sat said, I'm very had a face-to-face connection with my clients. So the method could be to retain and loyalty relationship, word of mouth, human touch, and customer service is the method. Most of my clients that I assist are immigrant with language barrier communication and understanding the complex of the health insurance rules and regulations, and also cannot navigate to complete the application online in New York State due to the technology challenge. Speaking the language is very important to build up trust with them, showing understanding, resolving the problems they are facing is also part of the building up the trust. Many clients have to come to me with other issues than health insurance. I assist the client with medical bills sometimes, calling hospitals, applying for financial assistance, helping to understand Medicare versus Medicaid, calling the health plan to understand sometimes, and selecting the PCPs. So this is my service most of the time.
Thank you, Luz. And yes, I mean, obviously, Blooming Health, born and raised obviously in New York City, and understanding the challenges in the diverse communities that are being served. Really appreciate that you all lead with equitable access to care, and really is at the core of the work that we're doing as well. So thank you for that. One thing that often gets overlooked is that Medicaid renewal isn't really an administrative process. It's often happening during some of the biggest life changes people, are experiencing, whether that's losing a job, moving, recently becoming pregnant, managing a chronic illness, or caring for a family member or loved one. I'd love to talk a little bit about what those moments actually look like through your perspective. So Luz, beyond keeping someone insured, what downstream outcomes have you seen when you're able to prevent a lapse in coverage? So how has staying covered helped the families that you've served?
Well, I would like to answer this question by giving a story for one of my clients that assisted, and she had a medical issue. She's going to dialysis, and also she need to be on the organ donation list. She was referred from the dialysis center because her existing health plan carrier is not accepted by the hospital when they supposed to receive the surgery. I was able to assist her by calling the health plan, the social worker, the dialysis center, and the hospital to navigate and switch to the plan that is accepted in both location, dialysis center and the hospital. After that, thanks God that she received her transplanted organ after 6 months, and she feel healthy and enjoy her life, and she is super grateful to all my effort that I help her in this process. So I think this is the best example how we assist and help the clients in those cases.
Yeah, and I love this example too, Luz. Thank you so much, because it really illustrates how coverage determination can be a life or death issue. And, having the wrong plan or the wrong coverage at a certain critical time in your health journey
Mhm.
can really be, life or death. And the coordination that is required to understand um, what enables these different parts of the system to work together for a person's health, making sure, as Luz mentioned, two different types of providers are going to be able to collaborate and coordinate uh, on the care of this individual. So yeah, it's just a great illustration of kind of the human expertise that is brought to bear with the people that we serve when it comes to health insurance.
Yeah, thank you so much, Luz. Appreciate that anecdote and absolutely double clicking on everything you said, Zach. I think that naturally raises another question. Reaching one person is, of course, hard enough. Building a system that consistently identifies thousands of people before they fall through the cracks is something entirely different. So, Zach, how does Public Health Solutions build outreach triggers around Medicaid renewal at the organization level? Is it driven by data patterns? Are we seeing navigation feedback, or is there something else?
Yeah, so I'm going to talk about a little bit about the present, and then I'm going to talk a little bit about the future, because there's a lot in the pipeline to make this process more streamlined at scale. So we receive sort of a lot of lists of members based on different characteristics that the state is interested in, particularly people who move, people whose address has changed, people who have fallen off their plan. And, the old-fashioned way of doing things was just to really work that list. And so, of course, we do a lot of human outreach, and that's very important. It's something I think that will never be abandoned. But then as we have developed the infrastructure through our experience as a social care network, we've really seen the potential to, with navigators, uh, elevate and prioritize populations based on various characteristics. So we have the data infrastructure now that we can combine information about, people who have lapses in coverage or people whose addresses have changed with other factors that we know about their health. Like, are they pregnant or postpartum? Are they living with a chronic condition? Um, are they intellectually or developmentally disabled? And then, what that allows for, so on the social care navigation side of things, where we are already working to connect Medicaid members to food, transportation, and housing, we are able to prioritize and triage and lift up for our navigation workforce the most intelligent next right steps for them to take as it relates to outreach and engagement. And then we're also able to automate outreach engagement on lower uh, kind of, I don't want to say, I don't like saying lower risk, but just people who don't fall into some of those categories that you need to prioritize first, um, with more automated types of communications and outreach. And so when we think about the future state under HR1, and we think about the two main components of that, biannual recertification, meaning instead of just once a year, a health insurance renewal process, you're talking about having to do it twice a year. And then you're also talking about work requirements and um, needing to prove certain exemptions from those work requirements, or assist people in demonstrating that they do meet those work requirements through partnerships. We think that, with over 1 million people likely to be affected by those everyone's going to be affected by the biannual recertification process. So we need to see who's most at risk of falling out of that biannual recertification process, both administratively and because of their life circumstances. And then on the work requirements, that's almost 1 million people, I think, statewide. So on Medicaid, that would be like 1 out of 8, 1 out of 7, 1 out of 7 people that is going to be impacted by the work requirements. And so handling that 1 million folks is an infrastructure challenge that we're confronted with as a social care network and as a health insurance navigation program. And so what we're really thinking about carefully and looking at as our plan of action is we cannot replace Luz's expertise with the folks who really need hands-on assistance inside the exchange. But you know what? We're not the only health insurance navigation program. There are multiple health insurance navigation programs across the city and the state. Also, the health insurance navigation programs could use support through different types of partnerships that we're connected to and are available in our network. Behavioral health providers, intellectual and developmental disabilities providers, voluntary service organizations that can assist people to meet the work requirements, job and workforce training programs that qualify individuals for the workforce programs. So that's incredibly powerful infrastructure if we can leverage it to prevent folks from falling off of insurance and guiding those who need proactively guiding those who need that hands-on support with the exchange specifically to the health insurance navigation programs is our game plan with the infrastructure.
Thank you, Zach. It's interesting, even when organizations identify people at the right moment, there is, I think to your point, no single organization that solves the problem alone, right? We're all working together to kind of tackle this really complex, issues that we're facing, and to be able to ensure that folks don't have their coverage disrupted. To this point, that amazing story in terms of making sure that at that critical moment, that individual was able to maintain her care and still be supported in navigating that is I'm sure something that can never be replaced. So when everybody is talking about closing the loop, we hear that quite often. I'm sure you all know, and shaking your heads if I could see you all virtually. But organizations still operate in silos. Zach, what have you learned about making hospitals, health plans, community-based organizations, and navigators actually coordinate around one shared outcome?
So I want to dispel the notion that this type of coordination is new. I have, been around for a while now, and I come out of HIV. And I mention that because HIV, I think in public health history, stands out for its recognition that people were going to die if social needs weren't met and accounted for. It was sort of the first time that people connected the dots between social needs and treatment adherence. And that was created into policy, which was called Ryan White, and that built social needs services around HIV care and coordinated between community and healthcare to ensure that people could engage in preventative care, adhere to their medications, and achieve and maintain viral suppression. So if you want to think of that as like our national pilot, our devastating and horrific national pilot, that's the experience that we bring into a new era where the potential for technology can accelerate and support and expand and enhance that coordination. Um, so uh, when what we have learned in the building of that technology infrastructure, and introducing that among those diverse partners is that you really have to make a lot of uh, the hardest part is not the tech solution. The tech solutions can do like almost unlimited things if you allow them to. Um, the hard part is with those stakeholders, each one has a slightly different set of priorities that they're trying to accomplish with that member. And the kind of orchestration of that when you are the holder of the technology is the biggest challenge, balancing those priorities and working them. And you know, we what is wonderful about all of this, though, as we learned with HIV, is that the the glue, the place that we always return when we have to make decisions about which part of the infrastructure, what do we interoperate, who do we reach out to first, is going back to Luz's example, the best interests of the member, the best interests of the person. And that's how we kind of make the decisions around the technology that we deploy, and is what I think results in the best public health outcomes at scale.
I truly appreciate that. And yeah, it's quite a feat when we think about interoperability and aligning priorities and to root that in terms of what exactly is the best, or obviously the challenges that they're facing when it comes to their member population and patient population. So yeah, appreciate the collaboration and the idea of that orchestration model, right? Where we're all working together. Let's think of this holistically and set our priorities in one pathway and kind of make sure that this is, I think, what is that phrase where it's the perfection, you know, striving for perfection will delay productivity or, you know, impact and so on. So appreciate that point of view, Zach. You know, we're also seeing Medicaid evolve beyond traditional healthcare. Increasingly, states are investing in nutrition, housing, transportation, and other social drivers of health. Food as medicine has become one of those, right? One of the ones that have become more visible of examples of that particular shift. And I would love to hear, you know, where does that fit into WholeYouNYC's model? And what would it take to build food access into the core of care coordination rather than treating as just a side referral?
Yeah. WholeYouNYC and the social care networks writ large, I would say, have solved a challenge that the state was attempting for quite some time as it relates to food as medicine, um, by bringing food as medicine to scale in New York. If there is one win to this demonstration period, I would say it is the extent to which social care networks and the underlying technology infrastructure have brought food as medicine to scale. Of the to date of the 160 million that we have paid out in services, about 80% of it is for food as medicine interventions. And that dwarfs any previous initiatives related to food as medicine, and kind of the previous method, which was we'll allow plans to pay for it through a method called in lieu of services, which got relatively small uptake across the state. This is miles and miles and miles beyond that from a policy perspective. So what is so that's incredibly exciting. I think what I always want to you said evolving beyond healthcare, but food as medicine really is healthcare. And I want to differentiate between like food insecurity and what the social care networks are doing with food as medicine, because we while we are bringing it to scale, we're bringing it to scale in a very targeted approach. This is not like we're not going to solve food insecurity with like the food as medicine channel. Um, we are introducing what the technology enables us to do, and all the data that we have enables us to do is target food as medicine for people who have nutritionally sensitive conditions, reach out to them and ensure that they have the access that they need. And what's especially exciting about social care networks and differentiates it from previous approaches is the diversity of community-based organizations that are providing it allows communities like New York City, which are very, very culturally diverse and dietarily diverse and religiously diverse, to have halal, to have the spices that they cook with available within the context of these interventions so that they actually get used. Because if you have, one large plan and like one large food as medicine provider operating in a region, there are a lot of people that are going to say, no, thank you. Like I have to eat halal food, or I'm a vegetarian, or this doesn't taste good. So to me, doesn't taste good to me. So that is something just remarkable and exciting about the work, and we've gotten great feedback from the communities as it relates to food as medicine.
Wow, that's extremely exciting. I have a follow-up question for that, Zach. Um, as you continue to develop this program and strive for the success around it, are there any kind of dream data points that you'd like to see? Is there anything that would really be able to kind of give you a full picture of the individual themselves to navigate this? I know this is a little bit off the rails, but yeah, I'd love to hear that, Zach.
Well, I'm going to take the opportunity for a soapbox here, um, and point out that food as medicine is an established, effective um, medical intervention. And I say that because we are consistently asked to prove the efficacy when we are, approaching folks about introducing this work for certain populations in which we already know it is effective. You wouldn't, if a new drug became available on the schedule for a condition, and a new practice wanted to start administering that drug, a new primary care practice wanted to start prescribing that drug, you wouldn't ask that practice to prove the efficacy of that drug. Even if, you know, the uh, even if the clinical trial, if it met the standards of a clinical trial, of a randomized controlled clinical trial, um, and it was approved on the schedule, you wouldn't make people reprove it. So our role as a social care network isn't really proving it works. What we are interested in bringing in terms of clinical data is to show that we are getting uptake where it's most needed and impactful. So we're constantly looking at our enhanced populations, our populations who have those nutritionally sensitive conditions, and how does our uptake for the meals, how is it distributed across those populations is where we're focused.
Appreciate those insights. Thank you, Zach. Yeah, I'd like to shift gears for a quick moment and talk about the people doing this work every day. Technology continues to evolve quickly, but navigators truly remain at the center of member success, member patient success. So Luz, love to hear, where does technology genuinely save time today? And where do humans remain indispensable?
Sure. Electronic applications make us more efficient than we used to do with a manual and less paper. So that help. To me, customer service and ongoing community are the keys to succeed. My role doesn't end after client enrolls in coverage. We often need to do telephonic educational outreach to the clients who did not consent to text message. Each client will call 3 times, or we're doing 3 times attempts, and the clients who consent with receiving the text message as well. This continual communication allows clients to questions and address their concerns. We can support clients entirely over the phone. However, clients often request in-person, like hands-on support, particularly in communities we serve. That's most of, so it's important the human communication and actually both band together. They both hands together, the technology and the human touch.
And if I could just piggyback on that a little bit, we learned a lot during COVID-19 when we were forced into kind of telephonic and all virtual types of services. And we did see huge disparities, and particularly troubling ones around the aging and the blind and disabled during that time. And then we also saw in other populations increased preference and reliability on technological interventions and virtual services. In the current climate for immigrants, also we see differing levels of comfort with in-person versus virtual services. And so going back to the equitable approach, it's the hard path, but it's the necessary one to deploy multiple techniques. And an example that we learned from the social care network, and also to highlight and feature our work with Blooming Health, is the technology capability, when you haven't established the trust that Luz mentioned, has a lower ROI. So who is deploying? The first question to ask is not what is the technology capability, but who is the right actor to deploy the technology innovation? Because we had these clients from health insurance and from WIC who had consented for text outreach from us and had become sort of accustomed and acculturated to communicating with us in that way. And when we ran campaigns, when we launched Blooming Health, which has incredible capabilities, it allows you to have a preference of email, voice, or text. And it has AI-enabled capabilities if you're comfortable with them. But when we began the sort of deployment of these campaigns, and we would compare the campaigns where we utilized those PHS clients who had consented to receive text message, we saw huge responses because these were people who were already accustomed to hearing from us about their benefits eligibility and their and communicating with their navigator or communicating with their WIC program via text or via chat. So when they saw that come in from us about these new services that were available through the social care network, they said, oh, this is not spam, right? This is not a hoax. This is not fake. Um, these are the trusted, this is the person I trust telling me about something new. And so those campaigns were incredibly successful. And the key takeaway there is not like, can the tech capability solve for this, but who's going to get the best ROI with the tech capability because of that trust and how it's deployed.
Absolutely, certainly. I could truly understand that. And
Mhm.
thinking about Luz and some of the work that you're doing and your caseloads, and obviously being able to manage those that have an appetite to be able to kind of navigate the automation part of that outreach, I'm sure is extremely helpful to figure out and differentiate where to spend most of your time. I could imagine Luz where there might be more of those complex, that one-on-one that requires that extra time that you're saving around monitoring overall, utilizing some of the technology that I'm sure is quite helpful. But I think that naturally brings us to AI. I think every conference that I've been to this year, and perhaps maybe in the last year or 2 years, has AI in the title somehow, right? But there's an important distinction between replacing human relationships and expanding human capacity. So I'd love to see where each of you sees that balance. So, where do you believe AI can genuinely extend your team's capacity, and where should humans always stay within the loop?
Um, so, artificial intelligence means so many things, and we were all using it before we recognized what it was. And I think we are enthusiastic about um, many of its applications, and particularly those that ameliorate um, many previously very manual and time-consuming tasks of not the losers of the world who spend, 90% of their day having these human-to-human encounters, but the supervisors of the losers of the world who receive these kind of lists or are tasked with determining the caseload. I hate this terminology. The population to focus on, the community to focus on, um, and what we have. One thing we're really excited is about the potential and power to surface for navigators the best kind of next person to reach out to and to talk to. Additionally, um, we are in the process of deploying the artificial intelligence screening. And you might think, uh, you might think that would make some people uncomfortable or they wouldn't like it. But I think it's all about how you choose to deploy it and with whom. So again, going back to this idea of a couple things. One is if everybody needs to be screened and you know that there's a subset of the population that is uh, tech oriented because they prefer certain means of technology, why wouldn't you take that first step with them? And also then on people who you know um, that there's a um, a logical next step depending on how they respond to a certain question, because people really appreciate if you're not going to waste their time. And, particularly in the case of social care networks, these are very targeted services. You know, everyone should be screened for eligibility, but only a subset for only a narrow subset is there truly a next step. And in that case, you really are being customer friendly and customer service oriented by not taking people through a lengthy in-person process or a lengthy manual process when you could sort of automate the right questions first and move on if a person is not appropriate for the resource that you're offering, or redirect them automatically to a service if they indicate a need but they're not eligible. And then someone doesn't have to um, figure that out and redirect them on their own, which might take days or weeks, but rather send them straight to health insurance, send them straight to WIC if they are not eligible for, the social care network. Um, and where that relieves the burden is not necessarily, as I mentioned, on the losers of the world, but it does take a lot of um, ex administrative costs is the failure of the American healthcare system. We have the greatest innovation in the world and the greatest interventions in the world, and we really actually have good accessibility to healthcare in terms of what is available. But the connection of people to that is so inefficient because of the complexity, um, that we have these runaway administrative costs, and the vast majority of resources are not actually spent on the care. And so this is where AI enters in and can have the costs be resourced to where they're going to be most impactful, and cut out all the time and effort involved in getting people to loose. So that when they get to loose, they belong with loose, and she can really help them the most effectively.
Truly appreciate that. And Zach, I love the approach. When you really think about it, I think we say this quite often and it still resonates. We don't want to leave anyone behind, right? Obviously, you want to make sure that we're reaching them in the language and the channel and so on. But I love the idea of thinking about we will always never try to leave anyone behind, but at the same time, if folks are somewhat ahead and their digital literacy maybe was somewhat advanced, are we making sure that they are well supported and navigating through that in that way and creating efficiencies across the board for all the different subsets of the population? Really appreciate that approach and those insights. Kind of circling back over to work requirements and looking ahead, the operational challenge is only getting larger. With new Medicaid work requirements and the increased renewal activity on the horizon, organizations, as we know, are preparing for significant higher outreach volumes than what we've seen before. So starting with Luz, as those renewal volumes and work requirements do increase, what operational bottlenecks do you worry around the most? So is it staffing, engagement, documentation, or something else?
Yeah, I think the proof of income is already a burden and challenge for the client we serve. and most of them are undocumented laborers, seasonal workers, and self-employments are particularly hardened to document their income, difficulty to know what is acceptable. So they require a lot of hands-on and all support most of the time.
So we, and to take that to scale a little bit, we find the biggest challenge is the complexity of the rules and people's um, are people who are the most at risk or falling off health insurance also have the most challenging set of rules to comply with.
Mhm.
And that's where the health disparity comes in. And it's also one of the limitations around um, uh, it's one of the tech design challenges because um, what you have is so many unique sets of circumstances and rule sets to try to build in. And if a person doesn't know how to respond to a form with the right answer, they're not going to know how to respond to an AI with the right answer. Um, and so when we think about new requirements and new complexities, um, the goal is to really utilize the technology to take that first step of bringing certain cohorts of people to us. And also deploy the technology to make the partnerships and coordination around the people more efficient. So, right now, if someone comes to us and we take a look at their proof of income and we realize, like, if work requirements were in place today and we realized, oh, you need to do something more or you're going to lose your health insurance. Well, how do we reach them with sufficient time in advance? Technology. And then if they reach us and then we realize they need to do something like get signed up with a volunteer program or um, enroll in a job and workforce program or have their doctor give them some form of proof that they're exempt, um, the old-fashioned way would just say, you need to go do this and give me back the documentation. And with technology, we can do much better with that side of things as well. But again, that doesn't alleviate um, the need for the person who's going to translate the requirements into a language that a client will understand and explain it to them in a way that they give the right answer and not the wrong answer. So I caution around like um, an overestimation of the ease of explaining the rules to an individual. And that's the thing where we can't, we we still need, we still have a long way to go when it comes to technology, but getting the person to us at the right time, using the infrastructure and then uh, surrounding the workforce with better resource connectivity is where the secret sauce is, I think, when it comes to Medicaid retention.
So very true, Zach. I know we're somewhat getting to the wrapping up of the hour here, so I'd love to leave the audience with something practical. Um, Thinking ahead, if organizations wanted to replicate what Public Health Solution has built, what's that one piece of infrastructure or partnership that you tell them to build first?
You really have to have, I would say, I'm going to take that as a trick question and say it's the human uh, infrastructure that you have to have the experience with first.
Mhm.
But then if you're asking me specifically um, about the technology infrastructure, um, I'm going to also answer it in a unique way and say that it's actually not any one piece of infrastructure that you need to make sure that you um, build well first, um, but that you have done that um, exercise of that I mentioned before of what you are solving for first so that you can select the right piece of infrastructure first because maybe it's a data warehouse because maybe there isn't a single platform that's going to solve the challenge that you're trying to solve for. Maybe it's actually the service documentation platform itself, like a medical record system, or like in a social care network, we have a social care platform. Um, Maybe it's automated communications because actually the real challenge isn't um, what system you have in place for providing services, but getting people to you in the first place or getting the right people to you in the first place. And so my advice for any organization trying to do this is to go through that process thoughtfully about what needs to be solved for first so that you select the right partner or partners to move forward with.
Absolutely. Thank you so much, Zach. I think I'm going to take the next few minutes to just quickly share with you a little bit of we've talked about several problems and challenges that PHS and everyone I'm sure on this call is really keeping top of mind. So I'd like to just take a quick moment to kind of talk a little bit about Blooming Health and how we were built to solve some of these challenges. And after that, with time, obviously remaining, a few questions to make sure that we've kind of tackled everything top of mind for you all on the other end. But thank you, Marina, for pulling up the care enablement workflow portfolio here. So as I've mentioned, the conversation really has had a recurring theme. Healthcare doesn't have an outreach problem. It has a workflow problem. Organizations know who they need to reach, right? Screenings are happening, data is being analyzed, predictive analytics are being leveraged. And the challenge is engaging people consistently, supporting them through those barriers, coordinating across teams, and confirming that the outcome confirming that the outcome was actually achieved without overwhelming already stretched staff. At Blooming Health, we call these care enablement workflows. So rather than offering another communication tool, we build AI-supported workflows around specific operational outcomes. So every workflow begins with a trigger, whether that's an ADT discharge after leaving an ED visit, an upcoming Medicaid renewal, an annual wellness visit that's overdue, a pregnancy milestone, a chronic disease management opportunity, and so on. And then from there, our AI engages members through voice, text, email, and web. And as Zach had mentioned, really meeting them at the digital channel that they prefer. We're able to do so in over 80 different languages, adapting to outreach based on each person's behavior and preferred communication channel. But engagement is only the beginning. So the workflow continues by identifying barriers through conversational AI. So whether that's the need for a ride to pick up their medications, whether that's uncovering a food insecurity, whether that's difficulty completing paperwork, really being able to kind of support documentation capture and being able to form fill. And then confusion about benefits, right? Being able to provide that education around that. And then, of course, other social needs. All of this then connects, once we're able to identify those specific barriers, we're then able to connect the individuals to the right internal teams or community resources. Every interaction is documented, escalates when it's needed, and it's written back into these existing systems. So care teams always know where each member is in the process. They're able to monitor this journey and be able to kind of intervene when needed, really saving their time and and being sure that they're utilizing their time wisely. Most importantly, we don't stop once a referral is made. We continue to follow up until we're able to confirm whether that member actually received the service, whether they were able to complete the renewal, attend that appointment, or resolve the barrier. And that's what we mean by moving from outreach to outcome confirmation. The beauty of this model is that it's really repeatable across almost any population health initiative. I know there was the slide before focused on a few specific workflows that we support. Right now, our workflows approach really supports navigating transition of care, chronic disease management, primary care engagement, maternal health, and social care coordination. So for organizations like Public Health Solutions and many of our other health plan and provider partners, this means existing staff can focus on those complex conversations where human expertise matters most, where AI manages routine outreach, provides education, reminders, that follow-up, that tedious follow-up that tends to bog down care teams today, the documentation collection and follow-up at scale. Especially with the new federal work requirements and increasing administrative complexities, organizations need a way to reach more people without proportionately increasing staff. That's exactly where care enablement workflows were created and provide value, helping organizations scale trusted, personalized engagement while improving operational efficiency and ultimately member outcomes. Wanted to thank you again, Zach and Luz, for sharing your experiences and lessons today. If there is you might have a time for one question that may be burning. Marina, are you seeing anything within the chat that we should make sure we address?
I do. Here's a great question. What experience do you have in finding and connecting timely with Medicaid recipients? How do you think your experiences in this area can be applied to the challenge of keeping current Medicaid enrollees compliant and enrolled? This was a question from Liz in our audience. Thanks, Liz.
We have an incredible year-over-year retention rate, demonstrating sort of the long-term, the value of the long-term relationship with the client, and the number one source of referrals that we have are friends and family and word of mouth. So people have had great outcomes because they continuously utilize this service. And so, our experience tells us that once you use a resource like this, you don't go back. And so our task with the upcoming policy changes is just really to bring more of the folks who most need it to the resource. And that's really where we expect Blooming Health and other such technology solutions to support us in that.
Well, thank you so much. I think that we might be 1 minute over. I really want to, again, thank you, Zach, for your partnership. Additionally, for bringing on Luz and to be able to hear her perspective, which we, rarely are able to be able to really have a better understanding of the work that you're doing, Luz. Truly appreciate it. So thank you for sharing those insights to you both. And thank you all. Appreciate your attention.
Have a great day, everyone. Bye.